Hi everybody, it's Katie. I just want to start by saying that I am trying to keep this within our 15 minutes. It's actually very difficult. I've recorded and re-recorded for about the last hour trying to see what I can do to make this both meaningful and also not go past the 15 minutes. So I just want to start by saying that all of these topics, any individual slide and probably 10 things on each slide, are articles and somebody else's whole program of research and are words that have many books associated with them for any one topic. So I don't want to do any of them an injustice. So I just want to say that it's a very, very broad overview of the topic in general, with hopefully some good what can we do about it at the end. Okay, so I just wanted to start here by saying really worldview, bias, lived experiences, three big phrases again that you can go and find tons of information about any one of those things, especially in nursing research. Nursing pretends to be more focused on the lived experience. If you Google that or put it into like a CINAHL search, you will find way too many things to ever look at. So just know that those words are there, that they are a part of everybody's identity. Identity can include race, language, what your sex is, gender expression, your sexual preference, religion, class, educational level, ethnicity, intersectionality, which intersectionality just means that you are a combination of a bunch of things. You may have all privileged identities. You may have some that carry privilege and some that don't. And you may have many privileges that, many identities that actually don't carry any privileges at all. So we are a combination of them. For me, as your speaker, I am white, English speaking, female, although tend to be tomboyish, heterosexual, pagan, middle class, postdoctorally prepared, English, I would say English speaking, Italian and Polish American, and then holding invisible disability. So things that are invisible identities are basically those that require somebody to disclose them for you to even be aware that they have them. Sexual orientation is one of them. People who have, say, a traumatic brain injury or a memory issue. Obviously, if people have advanced Alzheimer's, we become aware, or advanced dementia. But if people have short-term memory issues, you might not notice. People who, depending on what someone's religion is, unless they're wearing a piece of jewelry or wearing a hijab, you might not know what their religion is without them disclosing that to you as well. People who have mental health issues as well would fall in that category. So somebody who has, say, a history of alcoholism, that would be invisible. You wouldn't know that unless they disclosed it to you. And also wanted to share that the presentation is being made on what were formerly indigenous lands of the Connecticut Sycowax. Wherever you're listening are also on indigenous lands of some other group of people, and recognizing that as a part of our history and our identities as well. You know, for most people, they don't think about those identities if they're in the majority. So, Christianity is a really good one. There are a lot of things that, although this has changed and may be different depending on where you are, where people are very comfortable saying, say, Merry Christmas to everyone, or, what different things are, assuming people all celebrate the same thing of, oh, what are you doing this weekend for Easter? That kind of a conversation comes from a place of privilege. You don't normally notice those things unless you tend to be or belong to that other group. And that happens with any of these identities, that you might not have had to think about, what my primary language is, unless you also are bilingual or multilingual. So I just wanted to start there so we can have the rest of our conversation. And then I'm actually starting sort of at the end of what can we do from here. Read up. There is always more to be learned. I learn something new every day. And actually this just happened. So this on the 8th, the American Holistic Nurses Association just put out their position anti-racism statement on just today. And we'll be compiling a reading list for nurses, which obviously is going to take some time. This is my list if people are interested. All of these are based on racial discrimination in healthcare. Good reads. Body and Soul is actually about the Black Panthers and the work that they did in the community, specifically with access to healthcare. Medical Apartheid. Minority Nurse is not a book. It's actually a periodical that has multiple things you can actually sign up online. It doesn't have to come to the house. Mary Seacole, Sojourner Truth, Harriet Tubman, who for me is not only my favorite historical nurse, but I think the best nurse in the history of the United States. But those are people that you can certainly have access to reading all about if you want to know about a more diverse history of nursing. And then this last book of Why Are All the Black Kids Sitting Together in the Cafeteria is not specifically about healthcare, but it's a really good introduction to anti-racism work and systemic racism. Some of the what else's can we do? So some of the things that have come up on COVID, one of the examples that's come up is how much telemedicine we've been able to use and for how long Medicare, Medicaid have said, oh no, we could never possibly, it's not as good, we won't reimburse. And now magically everyone's been able to do those things. We know that a lot of people, especially with Medicaid, have not been able to be considered compliant patients, that they can't continue to go to doctor's appointments when they're supposed to, mostly because of transportation. A lot of the doctors that take Medicaid patients are not usually in an inner city, and then people have to travel farther out for specialty doctors, and they can't get there because there's not one on a bus line, for example. But telemedicine has come into our lives with regularity, and all you have to have is a cell phone. Improving hospice access as well is something that we would advocate for, and I have suggestions below. Public outreach is something that we can do, community education about hospice, building relationships with those you serve, and I have those as separate because sometimes the communities that we live in are not the communities that we're also serving, and so what can we do to get to know the communities that we live in? We cover most of Connecticut, so the chances that you're going to be going into an area that's different from the one that you live in are really good. But what do you know about them and how have we interacted? And obviously now that everyone's on quarantine, our opportunities are not as much, but that will be coming back at some point. But getting to know a different community is a part of that outreach. And also outreach within schools of nursing, not just in talking about hospice and end-of-life care, but also in recruitment of diverse nurses from those programs. You know, direct recruiting is a pretty easy thing to do, to say we are looking for diverse people of diverse backgrounds. We are looking for racial diversity is a great thing to say. You know, we certainly say that when it's male nurses that we're looking to recruit. Oh, that's great. We love to have male nurses. You know, to have that statement be acceptable, but it's also acceptable to say you bring a diverse background and a diverse set of lived experiences. And we welcome that and we encourage it. That's a part of inclusivity. Having training on culturally responsive education. So, and I mention this just because there's a ton of this out there. So my program of research was on empowered holistic nursing education, which comes up in the next couple of slides. There's tons in education. So like education, like primary, secondary school, the people who do that their research on education, there certainly is culturally responsive education for them, but we didn't have anything that was specifically for nurses. So I wrote that. And I think it's important because we do education all the time. It doesn't just have to be in a school of nursing. We're in patients' houses every single day giving them education. But are we just teaching them what we think that they should know in a way that we would like to learn it? Are we basing it on any of their identities, on their culture, on their religion? And there are ways to do that. So getting training on that, I think, would be very helpful. Studying their professional history of racism. So I already just mentioned Harriet Tubman, Mary Seacole, Mary Mahoney. Most people know of her as the first trained African-American nurse, but then they don't know about all the things that she did that were anti-racism based and working on segregation. The American Nurses Association, the ANA, was pretty segregated, and so she helped to desegregate that. Learning more about racism in healthcare and learning about disparities, any topic that you're particularly interested in. If you're interested in learning just more about generally about pain control and palliative care, about cancers, all different kinds of cancers, which I have some slides on those as well. But you can pick any topic and type after that racial disparities, and you will come up with information that will teach you about what are the statistics, what are the causes, what are some interventions that people are recommending who study this regularly. And then advocating for anti-racism policy from, normally I would say from where you work, but in our case, that's Hartford Healthcare. For example, many hospitals have policies that requests for white-only nurses are considered a refusal of care. And just by having that policy and making it a refusal of care means that you still get your reimbursement from insurances, but that you have a policy that supports our nurses of color and also our white nurses who then have to say, I'm sorry, that's a refusal of care. We don't do that. You can certainly go to another place if that's what you want, but we support our nurses from all backgrounds. To be able to say that and feel supported by the company that you work for. And that's come up in the meeting that we had just on Friday And it was sort of glossed over, and I think advocating have more people sharing. I did share an article with the people who were leading that after the meeting, of other hospitals that have done that, and that's what their policy is. And again, if it comes down to money, then yes, we can still get reimbursement by making it a refusal of care. That's just one small example of things that we can do. Recruitment is an awesome start, so getting people to come into the profession is wonderful, but keeping them there is better. So having more diversity is only a part of it. And doing an assessment of the percentage of nurses of color who have worked in a place and how many of them have left. If they were lost, were they then replaced by diverse nurses? So we have like a null loss. If the nurses of color don't stay, then that means the chances for diversification of leadership goes down. The last thing that I had heard, it's actually now in print, so it's not a research done by me, but somebody who was using Empowered Holistic Nursing Education. They have a particularly racially diverse team of nurses in home care, and so she was using that when she was doing education of her nurses. And for her, in a year-long study, it increased the retention of diverse nurses, improved patient outcomes, and had shorter lengths of stay, which for them was their goal because it wasn't end-of-life care. In my own study, the short and the long of it is that the diversification of the program in the first year was only about 20%, and by the 6th year it was 95%. So theoretically, after 6 years, that shows that it works. Increasing professional diversity certainly starts with education. Here are some things that we can do to do that. This is just, not to spend a whole lot of time on it, but the Sullivan report came out in 2004 and basically said that nursing and dentistry were the two least diverse of all of the healthcare professions. Everyone else seems to have been able to reflect what the overall population is, except for us. And then in 2017, the National Nurse Workforce Survey basically showed that the same thing, that not much has changed. We are still 90% white, female, heterosexual, middle class, able-bodied, Christian, which means also those shared lenses and social norms become what establishes professional values and what we consider to be professional nursing behaviors. That, again, if everyone around you is behaving and acting the same way, then this just must be how everyone behaves and acts. And so it leaves very little room for when people have cultural differences or expectations or experiences. Okay. Oh, wrong way. Okay. So just a little bit to talk about this. I'll go through it sort of quickly. This is, 5 quick bullets on some of the things that can come up with our patients. Basically, in terms of cancers, and there are many studies that reflect this one bullet. So it can be long bone cancers, non-small cell lung cancer, leukemias, whatever those multitudes are. There's a 10% less incidence amongst Black patients, but a 40% higher mortality. And a lot of that comes from distrust of the medical community. So they're not as likely to follow up on screenings, mammograms, colorectal exams, and so their staging at initial diagnosis tends to be higher because they've waited longer. Then that also leads to African Americans having less access to hospice care. Part of that is from insurance, but a lot of that is from MD referral as well. Microaggressions is a whole large thing. Again, one of those pools that you can dive into. But that experience with microaggressions leads to PTSD type impacts on health. So the same things that we would see with somebody who's had a combat trauma of nightmares and hypertension and disturbances in sleep and depression. A lot of those things that have come up, we've also seen with people who experience regular microaggressions as well. So this will be really important. I'm almost at the end. I got about another minute. About 75% of African Americans that have been studied usually feel like they won't be told the truth by a physician or healthcare provider, and that they might even be used as a guinea pig by providers. And why have we earned that? Because of things like night doctors, forced sterilization, segregated hospitals. Most nursing programs have talked about Tuskegee. So, any of those things, please feel free to Google and learn about the history of some of those events. But it's enough that I've had students in class that these things have happened to their grandmother, their aunt. It's not that long ago. We think of our patients that are from the Holocaust and how that trauma has impacted their children and grandchildren, and it's much the same. I only have these 2 slides, and basically color blindness and the golden rule: don't treat everyone as you would want to be treated, because that only works if other people want to be treated the same way that you do. And again, racism comes in many forms. It's not just overt racism between two people, but the whole structure and of healthcare is a big part of that.